And why don't we get going? So here we have a Holter tracing from a 12-year-old, and why don't we ask Dr. Mukhopadhyay what you think is going on here?
Good morning, Dr. Paz.
Good morning to you.
So I'm looking at the A and the strip which is labeled as A,
By
and
the
I
way, I
find
think this is I think this is a continuous strip. It's a very old strip, so I apologize, but I believe it's continuous. Or actually, I'm wrong. They're two different times. So yes, excuse me for interrupting. I'll now shut up.
okay. For A, I see a P and then a QRS and a T, and then the rest of the waves are 1, 2, 3, 4, 5. These appear to be similar to each other, and the rate is around 75. So I would say that's sinus rhythm. And then looking at strip B, which is at a different point in time, I can see it's starting with the QRS, cannot see the P because it's cut out from the tracing. Then I see something which looks like a T wave, and then something which looks like a P wave, and then uh, it does not see, and then the QRS complex is there. I don't see a um, the PR. I don't think this is conducting to the QRS complex
Why do you say
because
that?
the
Yeah.
PR interval appears to be it's very long. It's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it's around almost
400 milliseconds, right?
yeah, it's almost 400 milliseconds. It's very on the longer side.
Can you
Um,
conduct with a PR of 400 milliseconds? Remember, this is the
um,
same patient.
um, um, I I I'm I think so. Going back to the strip, I don't really see a P wave which is closer to the QRS, which would mean that it's conducting there. So I'm thinking that maybe then it's conducting and forming the QRS is probably getting conducted, but it seems to be a very long PR interval.
Right, which
Um,
another way of
yeah,
saying that would be what?
it's a first degree heart block.
Yeah, I agree with you 100%. I think this is probably an example of somebody who is conducting, as you said correctly, in panel A, is conducting with a normal PR interval, and then in panel B, for some reason, is conducting with a very long PR interval. Now, one of the reasons you're right to question whether or not those P waves are conducting. It's hard to say. And always when you're looking at a small little strip, it's, you don't know what's happening before or after. But and we're only looking at a single lead of the electrocardiogram, so we don't really know for sure if the QRS morphology is the same in panel A when we can pretty clearly and definitively say that there is conduction with normal PR interval versus panel B where there is not a normal conduction. But the QRS looks kind of similar, I think. It's at least narrow. Now, could that be a sinus rhythm with isosynchronous beating of the QRS at a rate similar? The only way to know that's not actually conducting, so it looks like it's conducting with first degree heart block, but in fact, it's not conducting with first degree heart block at all. The only way to know that would be to watch the tracing over like 30 or 40 seconds to see if they diverge from each other. If you take a caliper on this tracing, you'll see that the PR interval in the where the PR is very long is consistent. So that is suggestive of the fact that they're conducting. If they were diverging, if the PR was changing, that would suggest that there might be a subtle difference in a ventricular escape rhythm versus uh, the rate of the sinus node. And so it's always hard to tell with one. So if you had said that I feel this is sinus rhythm without conduction, that this is just, some kind of ventricular escape rate, I certainly could not say you're wrong. So you actually could get the question right either way. But I think this is probably conduction with just a very long PR interval. Anybody have any ideas on why someone who seems to be conducting with a sort of top normal PR interval at one time has at other times has this very gigantic PR interval?
I think it can be normal with a vagal tone if you're sleeping or
Yeah, you could have high vagal tone that could explain this. So, Mohammed, since you answered, when would a person have higher vagal tone during the course of their normal lifetime or day?
sleep.
Yeah, someone is sleeping. They could be having maybe they had a big meal just before they went to bed, and they're having a little reflux, stimulating their GE junction a little bit. It's not inconceivable. Um, I would say this PR is especially long, but that's absolutely right. Get 100% credit for that answer. Any other uh, possibilities as to why someone that is probably the most likely reason? Any other thoughts as to why someone could sometimes have what appears to be a very normal PR in panel A, but in panel B has a very AB normal PR interval? I mean, one option is that I was thinking is, could this be a sign that the patient has dual AV nodal physiology? We've talked about the fact that something like 30% of all humans have dual AV node physiology. And one of the reasons that the observation of dual AV node physiology during an EP study doesn't equal doing an ablation is for that reason, right? Lots of patients have dual AV node physiology, but do not have AV nodal reentrant tachycardia. But it is not uncommon that, I should say, occasionally when you do a Zio or a Holter on a patient who has dual AV node physiology, you can see this like in someone with AVNRT. And it's sometimes if you have a patient, for example, who has non-pre-excited SVT, we always talk about how the two most common diagnoses in the differential diagnosis would be either orthodromic reentrant tachycardia mediated by a concealed accessory pathway or AV nodal reentry. But if I see somebody doing this on their Holter, where they usually have a normal PR, but rarely they have a very long PR, that often could be a little clue as to the fact that the patient may in fact have dual AV nodal physiology. And if you were on call in the ICU and you saw this, you probably would do nothing about this, but it's an interesting observation. Certainly you'd want to note it in terms of what's going on in the future. Now, the one proviso I just explained that, if you see dual AV node physiology, you wouldn't just do an ablation for AVNRT. The one proviso is in somebody who has SVT. In those cases, as we've discussed in the past, we will sometimes do an empiric slow pathway modification in the setting of a child who is not pre-excited, has no evidence for an accessory pathway, and has clear dual AV nodal physiology. Sometimes we'll put in empiric lesions. But the point is, this observation alone would not warrant any intervention other than observation. I would certainly, if a patient was in the hospital, let's say for an appendectomy, and these tracings were picked up on telemetry, this is someone who I would at least have one follow-up with cardiology and perhaps repeat a Zio or a Holter to confirm that there's no higher grade AV block. Somebody who's doing this probably also has Mobitz 1 at different times. When the PR gets this long, it's not uncommon that that goes along with Mobitz 1 block as well. Any questions about that? Okay, forward. Okay. So this is ventricular tachycardia. And my question to you is, what do you think is going on in the atrium in this tracing? So let's just review the legend here. We have 3 ECG leads in this particular lab, which is the Tehran Arrhythmia Center. Dr. Magarefte was kind enough to give me this tracing. I'm just kidding. I found this on the internet about 20 years ago. We have 3 ECG channels, leads to 1, 2, and V1. We have a nice right atrial tracing, distal and proximal. The distal seems to have a very nice atrial electrogram. We have 2 Hiss channels. Remember, you're used to seeing at Sinai, in our lab, 3 Hiss channels. Some labs even put more in, so Hiss proximal and distal. You're also used to seeing us project distal above proximal, so good reason to just always look at the legend. And then at the bottom, we're seeing the RV electrogram, the distal electrogram, presumably in the RV apex. So any idea what's going on in the atrium here? I'll put it to the group if anyone wants to try to answer this.
I can take a stab.
Sure.
It looks like in terms of the ventricles, there's one-to-one correlation on the surface EKG and the RV channel.
Yeah.
And then when I'm looking at the RA channel, it looks like it's not quite regular, and the RA depolarizations are following the ventricular depolarizations. And actually, it looks like the Hiss, it goes first Hiss, then to the RA. So there's ventricle Hiss, RA, ventricle Hiss, RA, but then that interval seemingly is lengthening. So I don't know if this is the real possibility, but it looks like almost a Mobitz but like a retrograde Mobitz. Is that like a phenomenon that could happen?
Oh, it's 1 or 2.
1.
So if I might translate it, you're positing that the patient may be Wenckebaching retrograde. Is that
Correct.
what you think?
That's a much more eloquent way to put it. But
Well,
yes.
it's okay. When you're 30 years out of fellowship, you'll say it much nicer than I did, I'm quite certain. You are absolutely right, Vlad, and this is a very difficult question for a general pediatric cardiology fellow. So bravo. So what we're seeing here is VA conduction. So again, as Vlad said, these ventricular electrograms are corresponding to the QRSs here. And so not surprisingly, there is a V in the ventricular channel that corresponds directly for every QRS, because if there is an electrogram in the on the distal ablation, in the distal RV catheter, of course, that means there's depolarization of the ventricle. What's interesting is you notice subtly that the QRS is actually starting a little earlier than the onset. If we were to drop a line from the beginning of this to the beginning, it might be like this QRS looks like it's starting here, which is a little before the onset of that. That's because the catheter is sitting in the RV apex probably, and so the ventricle is actually depolarizing before the impulse ever reaches the tip of the catheter. It might be that you randomly and luckily get the catheter in the RV at exactly the earliest point, but anyways, that's a minor point. But you're correct. So what's happening is we have V, and I will just look at the high right atrium for clarity or simplicity. So here's the V, and then here's a retrograde A. And here's a V and a retrograde A. And we can see, right, that the interval between this ventricular electrogram and the onset of the atrial electrogram has gotten quite a bit longer. Here, again, we can see that this VA interval seems to be even longer. We don't have calipers, but I think just to your eye, you can tell that this interval from here to here is shorter than the interval from here to here. And then here we have a V and we have no A at all. And then the pattern starts all over again, just as it can antegrade. So here's VA with a longer interval, and then we have a V, and we don't see the A, but presumably the interval's even longer. And also, very astutely, you mentioned that the A in the Hiss is actually earlier than the A in the high RA. And that, of course, makes sense, right? Because the if there is no accessory pathway, well, first of all, we know that accessory pathways usually do not Wenckebach, right? They have non-decremental conduction, both antegrade and retrograde in the setting of WPW, but really in any setting. So if you have non-decremental conduction, then this kind of proves, or I should say, is another form of evidence to convince us that this is not going up an accessory pathway. Because first of all, the VA interval is very, very tight in the Hiss, which is what we would expect if it was going through the AV node, right? Because the Hiss bundle is sitting essentially immediately distal to the AV node. So we have an A, here's the V, and here is the A. We see this VA interval is very tight, and we also see that this A clearly is earlier than the A in the high RA. And that's just a reflection of the fact that the impulse is going up the AV node, and then the atrium is depolarizing passively from the anterior septal region where the AV node is located. And so since the RA catheter is often placed either in the lateral right atrium or in the right atrial appendage, and is oftentimes and usually not next to the Hiss catheter, it's not surprising that the atrial catheter would depolarize after the atrial electrogram in the Hiss. And so here it's even clearer. So here's the V and here's the A. Now, sometimes people ask me, how do you know when you're looking at this signal, which is the V and the A? Well, one way we know is by looking at the same exact impulses when they are separated from one another. So this Wenckebach allows us to more carefully and obviously see that this is what the ventricular electrogram in the Hiss bundle looks like. And this is what the atrial electrogram looks in the Hiss bundle. And so we can imagine that, this signal here at the beginning of the Wenckebach cycle, where the V and the A are much closer together, you can see that they're kind of smushed together, and we really can't tell precisely where the V ends and where the A begins. And this is one of the aspects of mapping when we're doing ablations that takes time to learn. But if you look at these signals separated, you could imagine that maybe the ventricular electrogram ends somewhere in here at the bottom, and the atrial electrogram here, because this part of the signal looks an awful lot like this. But it's to some degree, it's a little bit of a guess. And this is one of the things that all have seen me trying to teach Jack how to do. And it's one of the harder things to learn when you're first starting reading signals is, where does one end and the other begin? But anyway, it's just a nice example of how if you have the separation of the electrograms, you can then look back at an electrogram where they're very close together and make a guess as to where it is. But what's interesting is the relationship between the atrial electrogram in the Hiss and the atrial electrogram in the RA remains the same. And that's because the depolarization retrograde from the A in the Hiss to the A in the RA is not changing, but the conduction through the AV node retrograde is. And so, again, just like you can have a retrograde, you can have Wenckebach antegrade, and Vlad, you had asked this question, you can have a retrograde block. Now, this is an adult patient, presumably. We've discussed this in the past, but adults actually can can have VA block at baseline. I think as we get older, more and more patients do not have VA conduction through their AV node, but it is certainly possible. And in children, we see it very commonly. Occasionally, we do an ablation of a pathway, and then we see there is no VA conduction. But oftentimes, young people have VA conduction. And I don't actually know why some people seem to have it preserved their whole lives and others don't, but I do think that's probably a natural feature of aging that you lose VA conduction. I assume it's also a natural feature of aging that you lose AV conduction, but probably we don't live long enough to have that happen. But anyway, that's a very, very astute observation, Vlad. Any questions for anybody?
I have a quick question, sorry, more so from a logistics standpoint. So what is the utility of having the right distal or the right atrium distal catheter and RA proximal catheter? Is that just...
It's a good question. Honestly, I don't know, Ivana. I mean, I guess if you thought that the pathway or whatever you were ablating was near to that catheter, you might want to see which of those two was earlier. Also, we don't know what the spacing is between the pairs on the proximal and distal. In our lab, we use catheters which are, the electrodes are 2 millimeters apart, and the the pairs of electrodes, I believe, are 4 millimeters apart from one another. They could be, in this case, they seem to be at least 4 millimeters apart. And I just say that because the atrial electrogram in the proximal is quite a bit earlier than the atrial electrogram in the distal. So it does seem as if these are not, for whatever reason, these two electrograms are not next to each other. But this is all a long way of saying that basically, it's a good question you're asking, because you're basically asking, why are they displaying the proximal right atrial electrogram at all, since you've never actually seen that probably with Barry or me when we do EP studies? And the answer is it's very idiosyncratic in my experience. And it highlights why it's very important when, when you're taking your board exam one day and you're given a question like this. And by the way, I would think this would be higher level question than would be asked on the boards, but I don't know. People are smarter now. Maybe they would ask this. But the point is, always when you're doing one of these questions, the first thing you should do is look at the legend and see which lead is which lead, because it can be confusing. I'm actually going to go ahead a little and show you a case. This, hold on, let me find it. Okay, 1 second. All righty. So this this case is very similar to a question that was in my boards. I think that since it was so long ago that I took my boards, it's probably okay to show it. It's not actually the original question. And I'm not showing it for all of the reasons that they're showing here, but one of the things that I wanted to demonstrate is that in this case, you notice that they put a catheter, the point I'm just trying to make is, this does not look like how we display things in our lab. And so you always want to look here, because they asked me a question in the board. This is an example of what could be a lateral accessory pathway. And they're trying to demonstrate, I think, in part, that the atrial electrogram within tachycardia is actually earlier than the atrial electrogram in the Hiss bundle. That's very different than what we just saw with our VA Wenckebach. The point is, we wouldn't normally have an RA catheter in the lateral right atrium. In other words, it's usually just sits in the atrial appendage. So you always want to look at the information that they're giving you. The other thing I would say is that the way that Barry and I demonstrate or display our images during EP case is very standard. So if you're seeing something very different here, ask yourself the question, why are they showing it different? And that's exactly what you did, Ivana. You asked me, why are they showing us the RA proximal? And the answer is, I don't actually know. But my suspicion is, like, a similar question would be, why are there only 2 channels to the Hiss? Or why are they displaying the proximal Hiss on top of the distal if you're always used to seeing it reversed? The answer is it just generally tends to be very idiosyncratic depending upon the electrophysiologist. So sorry, I don't have a great answer for that, but it's good that you asked that question, because it shows that you're thinking about, why are they demonstrating what they're demonstrating to you? Because there might be a reason. Sorry to interrupt. Okay. All righty. What kind of block are we seeing here? Let's see if anybody has any thoughts on this. And it seems that somebody was nice enough to tell us that the AH interval, which is of course impossible to guesstimate based on this tracing, which has no lines. I think these are actually some old tracings. One of my old colleagues, Dr. Ehud Krongrad, who sadly died a few years ago, when he retired, he left me a whole bunch. Dr. Krongrad had written a lot of papers on basics of EP, because he used to do EP studies in the era before ablation, and he just basically left me a whole bunch of books that he didn't want to carry home, and there were some old EP tracings, so I remember I took some pictures of them. So this is so they're telling us the AH interval is 50. So what do you think is going on here? Anybody have any thoughts? Yes.
Uh,
Please go right ahead.
For Dr. Paz, I'm looking at the His bundle electrogram. I see an AH. For the first one, I see an AH. I don't see a V. For the next two, I see an AHV. And then the couple after that, I see AH and not a V. So I'm thinking, is this, so I'm not able to see what's there before the first AH, but I can see that after the third complex, there are two AHs which are not conducting to the V.
Yep,
So I'm thinking, is this like a variable second degree heart block, type 2?
that's right. So that's exactly right. Excellent, Katoki. So what this is an example of infraHissian block. So we're seeing AHV. Interestingly enough, this is actually looks to me like infraHissian Wenckebach. So normally, when we say that somebody is Wenckebaching or Mobitz 1 block, what we're usually seeing is a conduction delay in the AV node. And remember that the AH is representing conduction in the AV node. Apologize for repeating myself, but I think that is helpful to learning. In general, we cannot record the AV node in an EP study. It's sort of one of the great ironies. We can record the atrium near the AV node. We can record the His bundle, but we assume that the conduction through the AV node is between the A and the H. And so we infer how AV nodal conduction is based upon how long it takes to go from the A to the H. And we remember that the normal AH interval is like between, say, 50 and 120 milliseconds in kids, or adults probably. And usually when somebody is Wenckebaching, the assumption is that it's happening in the AV node. And if you see AH prolongation, we would normally assume that that is a sign of just normal Wenckebach, but you're seeing it in intracardiac. But what seems to be happening, if we look at all of these AHs, which they nicely label for us, it's pretty clear that the AH looks pretty much the same, right, in all of these. It doesn't seem to be changing very much. But I do think that the HV interval, if we had calipers, I'm reasonably sure that this HV is actually a little longer than this HV. So this is a very odd or rare example of what I think is, probably infraHissian Wenckebach. And then, as you said, there is a Mobitz 2 or infraHissian block, right? Because we see conduction from the A to the H, presumably through the AV node, but we don't see HV conduction at all. And this is another example of how when you're looking at intracardiac tracings, you always want to use your knowledge of surface electrocardiography, because oftentimes, particularly in questions for the boards, they try to make the questions very, very straightforward. And so always keeping your eye on the EKG is very helpful. And it's very obvious, right? We see two QRSs and then we don't see any QRSs, just a bunch of P waves. And then it seems like there's a QRS at the end. So there's clearly not conduction here. And this is an unusual tracing. When you see this is if you're doing an ablation and you see this, you are not happy, because it means you just did something very bad by injuring the His-Purkinje conduction. Let me ask Dr. Capon. I just pronounced your name wrong. I'm sorry, Ivana. If you were looking at a post-op patient, sometimes you'll have someone who has heart block after surgery, and maybe we saw a little conduction and then we don't see conduction. And there are these cases, right, where people come back and they're in complete heart block and it's very obvious and everybody agrees, we should even do the pacemaker early. But no one disagrees whenever the time comes to put the pacemaker in. But every once in a while, you'll have someone whose conduction is coming and going. And sometimes people will say, well, why don't we do an EP study and see what's going on? I never actually do that. But in the old days, they used to do that with some frequency. Would this be the type of conduction? Let's say someone had a VSD repair. Is this the problem we would normally see in a patient who had intermittent conduction following a VSD, or would we see something different, do you think?
I don't believe we'd see necessarily.
So
So
I guess
usually,
let me rephrase the question. Would heart block from surgery be supraHissian, meaning at the level
yeah,
of the AV node, or would it be infraHissian? And which of those two is like, if you had to choose one, of course, we wouldn't want either, but if you had to choose
right.
one, which would you prefer to have?
So I believe usually we are concerned about injuring the AV node when specifically repairing certain VSDs and congenital heart disease. So I'd assume it'd be supraHissian. So this would probably give me pause in terms of outcome. And then I agree with the 7 to 10 day wait period in terms of waiting to put a pacemaker in.
So I'm glad I asked her this question. What you're saying to me is exactly what we say at the bedside every day, right? We're always saying, you know, you can injure the AV node, and we want to wait for the AV node to come back. But actually, it turns out that what we're really looking at is infraHissian conduction. The most common injury is actually below the level of the Hiss, and that's what we are most worried about. Or at least I should say, that's the most common reason that we end up needing a pacemaker. If you were to do an EP study on that patient who had heart block or intermittent heart block. And as you said, we're waiting our 7 to 10 days. So now let's say we're at 10 days out. We're not 100% sure. We're still seeing some conduction. What should we do? If you were to do an EP study, most of the time what you would see is something exactly like what's on this tracing, which is infraHissian block. InfraHissian block is considered a higher degree of block. And a more dangerous form of block. If this was problems at the level of the AV node, that would probably mean to me that might still be something that's not going to recover. But, and especially at 8 to 10 days, I would be much less optimistic. But most of the time when we're talking about somebody having heart block following it, we always say, you know, we've injured the AV node, but in actuality, most of the time, yes, the AV node certainly could be injured, but the most common injury is actually infraHissian block. And the reason for that is simply that it's a very, you know, gross form of heart block when the surgeon gets that accidentally. And it's probably, it could be both, right? I mean, you're putting a couple of sutures just in the wrong place. And it's not surprising that if you tie a knot tightly around the area where the AV node and the His bundle are, and remember, these are like millimeters apart from each other. So you could have one or the other or both. But it's the infraHissian stuff that really is considered higher grade block, right? That's why Mobitz 1 is you see AH prolongation, whereas in Mobitz 2, we're seeing infraHissian block. So this would be the more common type of thing we would see if we did EP studies, mostly in people who had heart block following surgery, and would be something that would, you know, worry us. I'm not saying that this would absolutely equate to you need a pacemaker, but if you were 8 to 10 days out, I think probably I would say this is equivalent to needing a pacemaker.
Thank you for clarifying.
Thanks. Yeah. So, I mean, it's an interesting observation and question because, you know, and I exactly understand why you thought it was at the level of the AV node, because that's what we always say at the bedside. And it's a good way of thinking about it. But in reality, most of the higher grade block is in the infraHissian area. I'm sorry, Katoki, I cut you off.
Just a follow-up, sorry. I was trying to interrupt you, sorry. Just a follow-up question. When you said VSDs, I was thinking that because perimembranous VSDs are like the most common form of VSDs, is that the reason infraHissian blocks are more common status post the surgery, or it doesn't really matter that much whether it's an inlet VSD or
Well,
like an
I
outlet
think,
VSD?
I mean, I think the answer is that all of these VSDs are, well, first of all, in an inlet VSD, right, the AV node may not be where it's supposed to, right? It can run along the inferior border of the VSD. And so the surgeon can get it there. Now, surgeons are smart, right? We all know to become a surgeon, you have to do well in medical school and, you know, you have to be a good, and then if you're going to become a cardiac surgeon, you have to be like a really good resident in surgery and apply and get in. So these are not morons. These are generally very smart individuals who become surgeons. And they have a very good understanding of the anatomy usually. But the problem is that not every heart has read the textbook. You know, sometimes we inadvertently impugn the surgeon when we report the echo, right? Every week we have sign out and we say, you know, patient so-and-so had a perimembranous VSD. He's going home tomorrow. We did an echo over the weekend. There's a residual VSD. And we all say that in a way that sort of suggests that we are, you know, that was some kind of an error maybe by the surgeon, albeit a minor one. But sometimes good surgeons intentionally leave one or two of the areas of the patch unclosed because of that exact concern. I've seen this with many excellent surgeons. They know that if they put their sutures in the wrong place, they're going to get heart block. But sometimes, despite doing it properly and carefully, they still can get heart block. It's happened to all of the greatest surgeons of the world. You know, this is one of the reasons why the work of the group in Boston with Lizzie DeWitt and Ed O'Leary mapping the conduction system during surgery could be very valuable. It's interesting to note, I was moderating a session 2 weeks ago in San Diego at the Heart Rhythm Society, and I was talking with families of children who have congenital heart disease and who have pacemakers. One of the patient had long QT syndrome and had a cardiac arrest, and she was 10. And two of the patients were young adults. They both had ASD with heart block, but one of them actually also had hypoplastic left heart syndrome, and all three had devices. And when I asked the patient, I asked the two young adults, actually, I asked the young lady who had hypoplastic left heart syndrome, I said, if you were going to sort of rate for us, what is a bigger problem in your life as you perceive it? Having hypoplastic left heart syndrome or having a pacemaker? Without batting an eyelash, she said the pacemaker was in her mind a much bigger issue. And the reason she said that was that it was her perception that it was restricting her from doing things she wanted to do. She had been told not to do roller coasters, which, by the way, I don't tell people not to do except in extraordinary circumstances. She had been told not to skydive, which, of course, I'm not in favor of for anybody. But the point is, the implications from a psychosocial perspective of getting a pacemaker, even though we all would say, right, as cardiologists, I think we would all think that if you got through your stage 1, 2, and 3, had your Fontan and you were a good Fontan, we would all think that that was by far your biggest issue going forward. But in the patient's mind, the presence of a pacemaker was a much bigger deal. So you know, I sometimes wonder if this idea of mapping the conduction system will become more popular, because I do think that avoiding a heart block, even with a great repair, might actually have a lot more benefits to patients than we think. You know, I mean, obviously, we're all very aware of the problems associated with chronic pacing, whether it's pacing-induced myopathy, difficulty of placing leads in patients, vascular access, lead breaking. There's a million things that can happen, but in general, right, we think pacemakers is a big nothing burger. Most patients do very well with pacemakers, but we should be aware of the psychosocial impact of putting a pacemaker in. And so most of the time, and I think even in Boston, they do not map standard VSDs because they feel they understand that anatomy very well. But pretty much for anything beyond that, like heterotaxy, complex baffling, double outlet right ventricles, they're mapping those conduction systems because they don't want to inadvertently put a suture in the wrong place and get what we're looking at right here on this tracing. So, all right, any questions about that? All right. Thanks very much. I hope everyone has a wonderful day.
Thank
Thanks, Dr.
you.
Paz.
Thank you. Be well. Bye-bye.